So for the management of neonatal sepsis, you're going to still use the SchrDbb algorithm. So in the management, you start by the disease, neonatal sepsis. So every time you have an infection, I've already told you that the principle of management of infection is you treat the point of focus and then you treat the systemic spread. Is it clear? Generally, in early onset neonatal sepsis, there is no point of focus. So you just treat the systemic spread. Is it clear? And the systemic spread that you treat, you use a triple therapy of the following antibiotics. Is it clear? So the first antibiotics you use is cefotaxime. You use cefotaxime. The dosage is 100 milligram per kilogram per 24 hours in 2 divided doses. Is it clear? The next one is use gentamicin. Gentamicin, the dosage for neonatal sepsis is 3 milligram per kilogram per 24 hours in a single dose. And then the last one is ampicillin. Ampicillin has the same dosage as cefotaxime, which is 100 milligram per kilogram per 24 hours in 2 divided doses. That is for the first line of management of neonatal sepsis. Is it clear? You do cefotaxime, gentamicin, and ampicillin. And now, in early onset neonatal sepsis, you need to know that what I've already said that generally the microorganism are treated there. You have the group B Streptococcus. Is it clear? And the group B Streptococcus is going to be targeted by ampicillin. Is it clear? We had Escherichia coli and the other Enterobacteriaceae is going to be targeted by cefotaxime, which is the third generation cephalosporin, which is used in children who are less than 3 months. Ceftriaxone is not used in this case because ceftriaxone is going to displace bilirubin from albumin and causes unconjugated hyperbilirubinemia. Is it clear? The ampicillin also is going to target only one microorganism, or is going to target only one microorganism is also going to be targeted by ampicillin, and that is Listeria monocytogenes. Is going to be targeted by ampicillin. And now the next one is gentamicin. Gentamicin is going to target the enterococci. The only microorganism, the only antibiotic that target enterococci is gentamicin, and also gentamicin potentiates the cefotaxime. Before that, if now you realize that you are giving the antibiotic therapy for 3 to 5 days, you send for hemoculture, and then you with a window period of at least 24 hours, and then you go to a second line while waiting for the culture and sensitivity. So in the second line, you have ceftazidime. We start with ceftazidime. The dosage of ceftazidime is similar as cefotaxime, that's 100 kilogram per 24 hours, but in 3 divided doses in ceftazidime. While amikacin, you instead give 15 milligram per kilogram, instead in 2 divided doses. Now, the meningeal dose of cefotaxime is going to be 200 milligram per kilogram. The meningeal dose of gentamicin is 5 milligram per kilogram in 24 hours, still giving you the same dose. Meningeal dose of ampicillin is 200 milligram per kilogram, still giving 2 divided doses. The meningeal dose in ceftazidime is 200 milligram per kilogram, still giving in 3 doses, and amikacin is 20 milligram per kilogram, still giving in 2 doses. And that is when you are suspecting that the patient has meningitis. Is it clear? So after the second line, you can now go to third line. The third line are the carbapenems. Example, you have imipenem, and imipenem now is going to be the dosage of the imipenem is going to be 15 to 20 milligram per kilogram in 2 to 3 divided doses. And then the last one is a fourth line. The fourth line is fluoroquinolones, and we only use fluoroquinolones. Generally, you need to know fluoroquinolones is contraindicated in children that do not have the complete growth of the growth plaques, that is less than 18 years. So when you have a child that is less than 18 years, it's always good not to use fluoroquinolones because it affects the growth plate. Is it clear? So the fourth line is a last protocol. Is it clear? Now, I've forgotten also tell you that what ceftazidime here is going to still be a third generation cephalosporin, and his action is that he has a anti-pseudomonal action. That is why, in addition to all those microorganisms, the other microorganisms that I've told you, which can be associated with the early onset neonatal sepsis, you have pseudomonal, which is have an anti-pseudomonal action with ceftazidime. Now the next management, so for the management of the cause now, you wait for the hemoculture, For late onset neonatal sepsis, I've told you that you have the point of focus, and when you have the point of focus, you give the antibiotics based on those microorganisms. And the microorganisms that can add up in cases where you have late onset neonatal sepsis, you have Staphylococcus aureus. And when you have Staphylococcus aureus being added up, you give antibiotic for the methicillin sensitive Staphylococcus aureus, and you give antibiotic for the methicillin resistant Staphylococcus aureus, provided that you have started with methicillin sensitive Staphylococcus aureus, and then yes, you are going to the second line. So the methicillin sensitive Staphylococcus aureus antibiotic is going to be cloxacillin. Is it clear? And you have flucloxacillin that you can start in a child, and then the dosage is 70 milligram per 50 to 70 milligram per kilogram in 3 divided doses. And then the last one is vancomycin, and the dosage is 30 milligram per kilogram in 2 divided doses. 30 milligram to 40 milligram per kilogram in 2 divided doses. So those are when you have used for the first line for the methicillin sensitive Staphylococcus aureus with the triple therapy, and then you realize that the patient is still having fever, while asking for the hemoculture and the culture of the particular point of focus,